so appreciate you coming to our fourth town hall meeting on our direct primary care pivot. We had a large crowd yesterday, and my heart is so warmed by y'all's commitment to having primary integrative functional medicine primary care in Gainesville. A little bit about the history of North Florida Integrative Medicine. I grew up in Gainesville since the 1970s. I went to the University of Florida College of Medicine on the fast track. I was actually the youngest doctor at the time to graduate from UF College of Medicine. My mom was on family practice, family medicine faculty, and she said, Angeli, you're in the top 10 of your class. Why don't you do something easier? Because she felt like as a family doctor, there was more and more paperwork, more bureaucracy interfering with her ability to take care of her patients. But because I grew up following her on house calls and I loved the doctor-patient relationship, I didn't listen to her. One of my mentors actually was my mom, but also at the time, the first woman Surgeon General of the United States, Dr. Antonia Novello, who just published her memoir. I was reading it last night. I was actually in the United States Public Health Service as well, because I wanted to deliver good medicine for the masses. And we knew there was going to be a shortage in primary care. So I didn't listen to my mom. I decided to do primary care. And I've loved it. I don't have any regrets. When I look over our charts, we have over 11,000 charts in our chart system, of which 3,500 are active, meaning we've seen you all within the past 3 years. It's been a pleasure. It's been a pleasure sharing functional integrated primary care, looking at root causes, trying to keep our patients healthy with a team of practitioners. Currently, we have Joey. We have Dawn, Joey's a PA, Dawn's a PA, and Shauna, who's an ARMP. And we sailed through COVID. I feel like we've kept you out of harm's way. We've had minimal morbidity and mortality. We were there for you every step of the way. We offer group medical visits, weekly to twice weekly, wellness checks, chronic care management. We have a care team that cares about you as an individual, not a number. We aim to exceed your expectations in how we care for you. Well, as a medical director, owner, and founder of North Florida Integrative Medicine, I was blindsided on February 21st when the Change Healthcare subsidiary of United Health Group got hacked by a Russian cyber attack group on February 21st. It essentially froze our ability to bill and therefore collect. Our cash flow froze. In this article from the Wall Street Journal from March 1st, medical providers fight to survive after Change Healthcare hack. Many practice with high costs and little liquidity, that's us, have gone more than a week without revenue. Our overhead is $25,000 per week, of which since February 21st, we've seen $5,000 to $6,000 per week. And much of that money has to do with you all. When this happened on March 3rd, I looked to make payroll, and all of a sudden there was such a drop in the checking account. I honestly thought I was embezzled for the fourth time. As a doctor, it's a very opaque system. You come, we bill insurance, 6 weeks later, we get paid. So I thought, well, I've been embezzled 3 prior times. 90% of private doctors are embezzled. So, but then I remembered my front staff telling me that they couldn't check benefits, that the website for the way we bill through Advanced MD, that's a company that uses Change Healthcare, was down, that they couldn't check benefits. So I actually looked at Advanced MD's website, and they said that they can't bill because Change Healthcare, which is owned by United Health Group, was hacked. So prior to March 3rd, I didn't really understand the cycle of a payment visit of a cycle for seeing you as a patient. So I wanted to take a minute to explain this to you all, because this was news to me. You come in and you register. We schedule your appointment. We actually see you. Then we send the bill and we invoice to a claims process. Then it goes to a clearinghouse. There's only 4 clearinghouses in the whole United States, of which Change Healthcare was one of them. And that's where our billing company bills through. And when that happened, they went offline. So we were unable to bill nor collect. In addition, in this claims adjudication, what happens is that the payors, such as Blue Cross and Blue Shield, which is our #1 payor, 70% of our practice, Medicare and United Healthcare, they adjudicate, they decide if it was appropriate, and then they decide if they're going to pay us, if we did the right thing, if we coded right. They get to adjudicate that. And there are denials, routine denials that, oh, that was untimely payment, untimely submission, or that wasn't appropriate. So they get to decide. Then we collect, and it's oftentimes 4 to 6 weeks later, and that's how the cycle goes. I have been in that system since I graduated from medical school 31 years ago. And when this is a very first time that this happened. So I actually had to understand that Change Healthcare was one of 4 clearinghouses, and they went down. So our billing cycle is now paralyzed and has been paralyzed. So what does that mean? So since February 21st, we have had an 80% decrease in our cash flow. So what are we to do? Well, March 3rd, I actually investigated this and I got scared. I'm going to be honest with you all. I came home, told my family, I said, I need to not hire a Joey, and I need to put a sign on my door that we're closing and I'll stay open for a month and tap out. So my family, my husband, Timmy and Derek, Derek was remote, but we had a family meeting and they said, Mommy, you have never quit before. You have to give this a try. And my husband, Tim's like, you're creative. Come up with something, try your best for 2 weeks, put on your game face and try really hard. Well, the next day, March 4th, I reach out to Congresswoman Kat Cammack and I said, here's your situation. Here's our situation. I have had primary care practice in my hometown for a quarter of a century, taking care of complex medical patients. This Change Healthcare attack is threatening to close our doors. Can you please help us? At least get Medicare to front payments for Part B. At the time, Medicare only decided they would rescue the hospitals. That's called Part A. They left our outpatient practices out of the equation to rescue. I said, please lobby, get that to happen. I need a small business loan, please. Health and Human Services. So they took me as a case, and they have been in contact with me ever since. In fact, I was on with their legislative aide from Washington, D.C., and I volunteered to speak at the hearing on commerce and energy that's coming up before Congress, because they need to know that small independent practices such as ours is being disproportionately affected. In addition, Aledade, which is another company that we participate in what's called shared savings for quality, they started fronting us some of the money that we earned for saving them money by taking good care of you, for having high quality care. So I had a little bit of there, and they had a webinar, so I understood the scope of the problem. Then I was told, then I reached out to my bank, because I'm fighting for 2 weeks, right? I said, bank, I've been a good customer of yours for the past 10 years. I've only had 6-figure balances on my accounts with 0 interest on my business account. I'm in a time of dire need, and so is a lot of other doctors. Can you give me a loan, and can you give me a good rate? So they said, well, we'll give you an 11% line of credit, a line of credit for 11% interest. Okay, so that's what I was looking at. So basically, I finally wrote a letter to you all, and you all responded. And this is what happened. So on March 4th or 5th, I wrote a letter to you all when you came in, sent a constant contact. Our billing is frozen due to this cyber attack. When you come, can you please front us $45? Because I did the math, 60 patients a day, $45 will help me to pay my staff. And let me tell you what happened over the course of those 2 weeks. You all not only fronted $45, we were getting checks left and right for $100, $200, $500, $2,000. Okay, you all have floated this practice. When I was interviewed by the reporters, I said, United Health Group is 100% responsible for this situation. I have received 0 front money or rescue money from them, despite the fact that they're bragging that they've given $3 billion out to doctors. I believe that this practice is a small fish in a large pond, and they're ignoring my 12 attempts to receive their advance payments. They haven't, I've had 12 documented attempts to ask United Health Group, which is 100% responsible for this, please, can you help our practice so that we can survive this cash flow issue? Nothing. I was told, my manager was told 2 weeks ago, they would actually call me. Nothing. I've been watching my cell phone. You all are 0% responsible for this, and you're continuing to pay your premiums to these insurance companies where I can't access that. You're rescuing the practice. Between last night's town hall and today, my heart is just glowing. I know this is going to work because we've had $22,000 in prepayment commitments for direct primary care for 2025, or the actual checks have come, even though I haven't even asked for them. People keep showing up and giving us checks for next year. And so I know this is going to work because you all are as committed as I am. And I'm committed because you're committed. And what I'm committed to is continuing to be able to practice high quality, functional, integrative, root cause primary care, looking at you as an individual, not a conglomerate. I need to know you with your own background, your own drug allergies, your own DNA, your own social situation, so that we as a team can take optimal primary care of you. Hospitals were affected, 3 out of 4 hospitals. And the workarounds that they're talking about with the billing, they're only 11% effective. Safety net providers such as myself could close. Pharmacy networks and payments and Medicare Part A hospitals were immediately restored because some people couldn't get chemotherapy. Did you know this United Health Group is so huge? It's in every aspect of healthcare, the way it affected us with the billing, the Change Healthcare, but they bought the CVS clinics. They are involved in billing. They're involved in drug pharmacy benefits. In fact, Corvallis primary care clinics in Oregon in mid-March, they went into such severe financial distress that United Health Group bought them. Not only did they contribute to their financial distress, they bought them. So they bought a series of primary care clinics in Oregon. I'm going to be transparent here. I've had multiple offers to buy this practice: venture capital, corporate, a company that's known for retail, that's now in the health market. I bet you use them every day. I met with them. They said they'd write me a check for $380,000 of my accounts receivable and take over my billing. I'm fighting to stay independent so that when I take care of you, my team and I can look at you and not have all that business interest or whatever the guidelines tell us or whatever corporate tells us to take care of you. I need them out of the exam room so that I can practice good medicine with a clear conscience. In addition, I told Congresswoman Kat Kamick that we have a primary care shortage in the nation, but especially in North Florida. This article just got published, the deadly shortage of primary care doctors. It's important that we are able to take care of our population frontline and be available to you to keep you healthy, optimally well, and out of the hospital system. Dr. Kennard said, the crazy thing is that there are still so many Americans who have no idea this is happening, and we still have no idea how much protected health information is now on the dark web. That's your personal information. All I gave them to bill was what was required to bill: your name, date of birth, your policy number, all that stuff. But guess what? The cyber attackers have it under their encryption key. Everybody needs to be watching their identity. Like I said, 1 in 2 Americans, it's estimated, has been affected by this, whether or not you have United Healthcare insurance. It's because United Health Group is so huge, the parent company. Dr. Gauker says, expect the next incident to be even more devastating. Earlier this week, there was a second ransomware group that reportedly tries to extort Change Healthcare again. Okay, the same way that they were just trying to get back on their feet, it's been attacked again. Now, my number 1 payer is Blue Cross and Blue Shield. I have received 0 payment for seeing all my Blue Cross and Blue Shield patients since February 21st. I've reached out to Florida Senator Keith Perry, who's trying to help me with that. Okay. My number 2 payer is I believe it's Medicare. Now, because we lobbied for Medicare Part B to distribute money, they gave me enough to cover about 10 days for 1 month. So now I have to apply for more prepayment because, again, I've had no Medicare money for the visits I've seen you all for since February 21st. I have had trickling United Healthcare insurance trickling in, But who's saving the practice? You all are saving the practice. I have liquidated myself some of my retirement investments to get us stable, but I don't know how long this is going to last. When I met with the huge conglomerate that you all get retail from online that moved into the healthcare market in January, buying $4 billion worth of independent doctors. They bought $4 billion worth of independent doctors and have their own network now. They said, don't let it fool you. This Change Healthcare attack will affect you for weeks to months. So here I am thinking, they got allegedly a second attack. I'm barely surviving it 7 weeks into this. If it's going to be months, I'm calling out United Health Group to say, front us $600,000 so I can sleep at night, because at least that'll cover me for at least the past 2 months plus an additional 4 months. Thankfully, we're getting some traction with national press at this point. And I was interviewed by Bloomberg. Okay, so apparently that's an outlet where the investors on United Health Group are actually going to read these articles and realize that patients, to me, it's you all, patients are being affected. Because I have served my hometown for a quarter century, I've grown old with you all. I have patients who are delicate, brittle diabetics. I have a blind brittle diabetic who comes weekly to change her patch. I have emphysema patients we have to see outside so they don't catch anything, keeping them out of the hospital. I have heart failure patients. I had a patient have a stent yesterday. She's going to need to be managed very, very carefully. If we close, there is not enough primary care in this town. Some of those patients will die. And I'm not being overly dramatic. Dr. Akey has options. I was offered a job, a really great job, doing functional medicine for the entire nation, telemedicine out of my house. I could be at my fishing condo and do this job. Didn't feel right to abandon you guys at this stage. I was offered to be bought out by venture capital right off the bat. Venture capital are business people who don't know anything about medicine, who's buying up small independent practices like ours for the profit. I was offered to be essentially bought by that big conglomerate that just moved into healthcare. That didn't feel right. At this point in my career, I'm in the evening of my career. I've been a doctor for 31 years. I've been practicing in this town. This is my 26th year. I needed to do what's right for you all and what's right for medicine. And what's right for medicine is that small independent practices such as mine are able to take care of their patients without outside interference, looking at them as an N of one, an individual with their own set of life circumstances, their own medical history, their own social history, their own struggles, their own SES, whatever they are, taking that all into consideration, being the best doctor and healthcare team that we can be, staying on top of the literature, which, by the way, the amount of medical knowledge doubles every 73 days. Every 73 days. So here I am studying every night to give you guys the best that I can give. And I actually teach this in our group medical visits, everything, all the latest things that I can offer you. I can't just tap out without a fight. So thank you for fighting as hard as I am, because I'm fighting for you all. And it's so heartwarming that the response I got within the past 24 hours and within the past week of asking you all to help has been tremendous. Did you know that since we started this letter to you all have contributed over $20,000? Did you know that since last night, when I put this appeal together, I got emails with commitment of, again, closer to $24,000 to prepay for direct primary care for January 1st to December 31st of 2025. I love Robert Frost. 2 roads diverged in the wood, and I took the one less traveled. And it's made all the difference. Because you know what? When I meet God, I'm going to say, I followed his will. That I tried really hard. And you know what? I'm doing it for you all. There's choices, okay? I want to steer us to a way where we as a team can continue to support you, and that I can continue to pay my 15 staff, of which 3 are the primary breadwinners for their families. So it's really important that we take care not only of you all, but I take care of my staff. I'm doing this for the patients of the past. I'm doing it for the patients of the future. I'm doing it for the pre-medical people that work with me. I'm doing it for my staff. I'm doing it for the independent, small, private doctor that I represent in this country. The United Health Group, which again boasted $371 billion in revenue in 2023, of which $22 billion were in profit. I'm going to say that again. In a press release in January, United Health Group said they had $371 billion in revenue, of which $22 billion were in profit. And I'm thinking, how many of my pre-authorizations for my MRIs, for my patients, my PET scans for my cancer patients, how many were denied? How much of that is in that profit, right? Now, I believe that if you work hard, you should get something, but $22 billion in profit. They bragged 2 weeks ago, United Health Group, that we're helping the doctors. We've given them $3 billion in advance payments. They're not even loan, they're advance payments. They're estimating how much that we worked so that they can give us a little bit of money until this gets open. So the way I do the math, they had $22 billion in profit in 2023. They've given us doctors $3 billion. There's still $19 billion out there in profit from last year that they can make things right. If they really cared, they would fly on their Learjet down to Gainesville, Florida, and come talk to me. Instead, I've been begging for a phone call for over 12 times to access prepayment money, which is money I've already earned. $600,000 could get us through the next 4 months. Direct primary care. Well, guess what? We can't count on that. We're going to do it ourselves, right? And it sounds like there's a lot of interest in our own population to do it ourselves. So direct primary care, this is the road we're traveling. Okay. I need feedback. There's a survey at the end. I'm going to announce the plan more concretely on Monday, April 22nd at 4:30 on another town hall. There's a lot of people coming live. So please, unless you can't use a computer, try to come on Zoom, because there's going to be over 100 people on that one. So what is DPC? It includes a flat periodic subscription fee instead of a traditional insurance-based billing system that's based on visits. There's currently over 2,200 clinics across the nation, and the surveys of DPC clinics say that there's a higher level of service and it strengthens the patient healthcare professional relationship. Here's a map. The green are actually active DPC practices, again, over 2,200. There's hybrid models, which are in the other color. So those are hybrid. We're going to be hybrid. I mean, I want to honor your insurance because you've had insurance until December 31st. We're pivoting completely on January 1st of 2025. Meanwhile, we are enrolling people who don't have healthcare insurance or who have insurance that we don't contract with, such as Aetna. We're currently enrolling direct primary care now. So we're in the middle of a hybrid until the end of December. Please, I'm going to ask my population, don't jump ship. If you can't afford the model that I think is very affordable for many people, I want to help you land safely and transition your records into another practice. I've actually put an outreach to my community doctors, see who's still taking primary care patients, because again, it's very hard to get a good primary care doctor in this town because there's a shortage currently. Why is DPC advantageous? Well, the standard visit's 30 minutes instead of 15 minutes. In our NFIM DPC model, you will pick Joey, who's a PA. He's primarily doing men's health. You've got Dawn, who's functional medicine. She's a PA. And nurse practitioner Shauna Duran, who you know well for 30 or 40 years already. I am the medical director. I'm still your primary care doctor. I'm still overseeing things. When you are sick, when you have something complex, I will be there for you. If you get some weird young cancer diagnosis, we've been seeing a lot of that lately. I'm there to help figure that out. Some weird autoimmune disease, I'm there. Some infection that you don't understand. So basically, most primary care, not over 95% of primary care, the studies show can be handled quite well by advanced practitioners such as PAs and NPs. The model we have, I've been teaching that doctors who are very, very well trained, I'm like triple boarded, and I've had a ton of experience in the emergency room and in hospital-based medicine. as well as my specialty, functional integrative medicine and regenerative medicine. Those are all my trainings for 31 years. I offer that to you when you need it. In addition, our model offers unlimited group medical visits, and this time you can come in from all over under the direct primary care model. You can come in from all over and whatever platform you want to use. You can sign up if you're self-insured. The panels are going to go down. So we currently have 3,500 patients. We're going to get down to 1,800 patients. So each healthcare professional will have 600 patients each, as opposed to the average, which is 2,000. That's the average. So we're going to be able to answer our phone calls. We're going to be able to be more available for you all. We will continue to offer same-day appointments and longer consultation times. So increase patient access. We're going to decrease cost. Number two, the generic price of drugs and labs, or we're going to pass on to you. For example, if you pull up as a drive-up evaluation outside and you have not COVID, you actually have acute bacterial sinusitis, and I say you need a Z-Pak, I don't have to e-prescribe that for you. Certainly, if you don't have any insurance, we're going to pass the savings right on to you. We'll check you out with $5. We'll just give you $5. We'll get you a Z-Pak. So we're passing generic drug prices right on to you. A 30-day supply of thyroid medication, $5. So we're negotiating prices for good drug rates. Now, if you have your own pharmacy benefit and you like to use that, that's great. But I would always look and see if you can even get better, either on GoodRx or with us. In addition, we are actually negotiating MRIs for people who are self-insured. The cost of a negotiated MRI in this town is $250 and it's red, as opposed to some people's deductible. You have to cover $1,000 before you can get your MRI done in red. The third is they've shown increased patient satisfaction with stronger relationships between you and us. The fourth is very interesting, increased healthcare professional wellness. With burnout reaching 70, upwards 70s, almost 80% now of healthcare professionals, it's become a high priority, even in the medical schools, to talk about this. So we were so blessed to be able to teach primary care doctors and professionals at University of Florida Innovations in Primary Care, Primary Care Innovations Conference about 3 weeks ago, how to do our group medical visits. It's considered a mark of quality to offer you how to be well and to teach you in group. The keynote speaker was not about primary care, it was about physician burnout. It's such a topic that's a major public health concern because they're not already, as of now, there's not even enough doctors to take care of you all, and doctors are retiring younger. You know, I read a study that said that of resident MDs, resident physicians, they finish medical school, they have their $200,000 to $300,000 in medical school debt. 1 in 4 medical residents are questioning why they became a doctor in the first place and looking for alternative careers. So this model will help me to attract other healthcare professionals so that they remember why they became a PA, NP, MD in the first place. The average, Dr. Reed did a study that says that primary care doctors need to work more than 26 hours each day to meet recommended guidelines for typical patient panel in the current insurance model because we have so many forms to fill out. You may see us for the average 7 minutes, which is the current average, but there's so much paperwork behind the visit every time to get you the care you need that it's very burdensome time-wise for many of us. I'm not sure why that happened. Hang on one sec. That's actually Dr. Steve Reed. He is one of the Florida Freedom Caucus doctors. Okay. So why I went into medicine was this. You know, I saw my mom, my brother's an oncologist, he's an MD as well. We made house calls with my mom, the doctor and the patient. It's a privilege to peer into someone's soul, be in their family. And I don't regret 1 second of my past 31 years. I love being a doctor. What I've seen over the past 20 years, since about the year 2000, was more and more interference to us taking care of you. The DPC model, we're out of this relationship, we're back to this relationship. So what is the proposal? What is our NFIM DPC model? It includes primary care visits, as many as you need to be well, and unlimited group medical visits. So We have a robust group medical visit schedule. Like I said, we teach other doctors how to do this. And I put all the latest knowledge into the group medical visits that I give you. I update them every single time we give them. And the price of a group medical visit when we have guests costs $75 per group medical visit. So just having access to the group medical visits puts this at $3,500 value. What we're offering here is a primary care relationship where if you're in the youthful range, age 15 to 29, it's $50 a month or $600 a year. If you're middle-aged like me, age 30 to 64, it's $75 a month or $900 a year. And if you're 65 and over, it's $100 a month or $1,200 per year. The average cost of an urgent care visit is $270 one visit. The average cost of an emergency room visit, not what's billed. That's a story for another day. The reason why if you were to look at the line items on the billing, when you go to institutions such as that, there says they've negotiated a percentage decrease discount. This says the average cost of an ER visit, $1,200 to $1,300 per visit. So when you come to NFIM in this DPC model, it's not going to look much different than what you've had, except you're going to have longer visits. The average, again, is 30 minutes and easier access to us. We're going to be able to answer our phones. You could read on the website how I personally have studied and trained and teach doctors all over the world progressive medicines, trying to keep on top of that literature that changes every 73 days in the world of medicine. You will have a choice to be the primary team member. And again, I'm right behind them. We'll do co-visits. I'll do visits if they need help, anything like that. Someone said, is Dr. Akey retiring? I'm doing the opposite of retiring. I'm working as hard now as I did during the pandemic to try to keep us stable. Am I retiring from medicine? I love medicine. I'm always a doctor. I love being a doctor. I'm right behind my team members. But you'll have to choose a primary one. So Dawn's one of the few PAs in the country that's IFMCP, Institute of Functional Medicine Certified Practitioner. Again, one of the few PAs. Every day she gets offered for another job that's easier and pays better. But yet she's as dedicated to this practice as I am. She's been with this practice over a decade. Another choice would be Shauna Duran, who's been practicing 40 years. She was one of the first ARNPs. She's actually a nurse midwife. She used to deliver babies in Haiti once a year until they became unstable. But she's a women's health specialist and a gut health expert. Joey over here, if you want to just say hi, just wave for the camera. Joey's our newest team member, and he's a D1 athlete, FSU football player, interested in optimal men's health. If you're a man, you want to be on Joey's panel because he's being groomed as the expert in optimal men's health, including testosterone optimization. So Joey's a great part of our team. So when this happened, when as I was trying to evaluate what is the next path, I called Dr. Lee Gross, who's part of the 120 MDs or part of the Florida Freedom Caucus of the Florida Medical Association. There are 120 doctors who believe that doctors should be free of interference outside of the office to take care of our patients. So we collated right after COVID, and I actually am the vice chair. So I actually reached out to Dr. Lee Gross, who founded his DPC practice in Northport, Sarasota area in about 2008 and has been very successful, not only in his practice, but in saving their hospital system $1 or $2 million. I sent the video out with the call for this town hall, and that's Dr. Lee Gross. He has been great at giving me advice and consulting. And then I met Dr. Chad Savage, who's the first DPC doctor in Michigan in 2010. So 2 weeks ago, maybe 3 weeks ago, they had the annual DPC conference, and I show up and I'm late because I was tired. It's Friday mornings in Orlando. There was no seat in the house. So I was like, I walked over here, no, the seat's taken. I walk over here, this seat's taken. I finally found, it was a dark room. I found a seat, and Dr. Savage says, oh, you could sit here. Well, it turned out that was the head table. I didn't realize that till later, but it was a God thing because he happened to be a Roman Catholic and asked for a ride to mass. So now we're quick friends. And I said, how much can I pay you to consult to make sure my practice is successful for my patients? Nothing. So I have the best people consulting so that we can continue to deliver high quality care in a DPC model for us. So now I'm going to ask my team to come up and go through frequently asked questions, because we've been doing this now for 2 or 3 weeks and we keep being asked the same questions. And then we're going to be opening it up for Q&A. Is this being recorded? Oh, thank you. And this is Caitlin. She's going to university. She's going to be a doctor in 4 years, integrative psychiatry. She's going to Medical College of Wisconsin.
Yes, hello, everybody. So I'm going to be taking you through some of our frequently asked questions along with Sarah. So the first question is, how is DPC different from traditional primary care? DPC has a set monthly subscription fee that allows for more personalized care and longer patient visits at a significantly reduced rate. This model does not involve insurance, therefore, there is more flexibility in managing patient care and more personalized comprehensive care at an affordable price. Traditional primary care, however, bills through an insurance company, oftentimes causing health professionals to focus more on quantity of patients rather than quality of care, and time is taken away to report quality metrics.
How is DPC different from concierge medicine? Unlike DPC, concierge medicine often charges insurance per visit in addition to annual fees, increasing its costs. In most concierge practices, insurance is still involved and copays and deductibles are collected at each visit. Additionally, in DPC, the healthcare professional is not available 24/7 as in most concierge models, though we are still on call as in the past. What is not included in the DPC model? Immunizations, wholesale pricing of generic drugs, and labs are not included with DPC.
And this is Sarah. She's one of our interns. Alex is going to read a couple.
So do we accept insurance? No, we will not accept any insurance plans nor bill them for primary care services in the NFIM DPC model. It will be a hybrid model until January 1st, meaning we will likely pivot off of the insurance like Medicare then. Do I have to pay copays and deductibles? There are no copays or deductibles involved with NFIM once we pivot to the DPC model.
Would I still need insurance? While we do care for patients who are self-insured and will be your primary care home, we encourage you not to drop insurance. It is important for referrals to other doctors and aids in navigating unexpected situations, such as ER visits, hospitalizations, surgeries, and other medical services not offered at a primary care office. It would be most beneficial to consider high deductible insurance plans, as this may decrease your premiums. You will no longer need to meet your deductible in order to have your primary care visits covered. This program works especially well with health share accounts such as MediShare, Christian Health Share, and Sedera.
The next FAQ is, what are the benefits for patients who have insurance? The DPC model allows for increased patient access and has been shown to have increased patient satisfaction. The monthly payments for DPC will be made in addition to your insurance, and telemedicine visits are encouraged when appropriate, such as for a lab review and chronic medication management.
What about Medicare? Should I keep Medicare? Dr. Akey is opting out of Medicare, meaning that NFIM will no longer be collecting any money towards Medicare. This will occur January 1st, 2025. However, the team will keep their PECOS numbers active with Medicare, so she and the team can still order services through Medicare, such as home health care, labs, and radiology. It is important to keep your Medicare Part B for outpatient services, referrals to other physician consultants, and the above services.
What type of patients are you targeting? We are targeting all of our patients, as we are dedicated to continuing to serve our patients with a better model for primary care. Patients who are self-insured can especially benefit from this model. We encourage those with insurance to continue their insurance for referrals, labs, imaging, and catastrophic care, such as hospitalization. What if I only seek primary care once yearly? Why should I pay this much a year? The DPC membership model includes primary care visits and group medical visits. You will have more access to healthcare professionals who will be at your service through telemedicine, phone calls, text messaging, and email, in addition to in-person visits. We will offer limited fee-for-service visits, which will be $300 for the initial visit and $150 for the follow-up visit. This is mostly for out-of-town guests and does not include a physical exam. These individuals are limited to 2 visits per calendar year and are not considered members of our NFIM DPC community. Is it like a subscription? Yes, it is exactly like a subscription. This plan includes a monthly payment at a reasonable price. Can I cancel my membership? Yes, you have the option to cancel your membership at any time. However, if you choose to re-enroll after canceling, there will be a $150 re-enrollment fee.
How do referrals work? Dr. Akey and team is still able to refer patients to other healthcare professionals. If you are in an HMO, you will need to go through your HMO doctor for referrals. For patients with insurance, there will be no change with referrals. Patients who are self-insured, however, will need to pay the healthcare professional they are being referred to. Dr. Akey will aim to negotiate lower prices for patients who are self-insured. And how does after-hours care work? You can call if you are experiencing acute, non-life-threatening symptoms and need to be seen as in the past. You may call, text, or email your healthcare professional questions that can be addressed the next business day, such as requesting an appointment or medication refills.
So those were the formal comments. Today we're down to the fourth NFIM DPC Pivot Town Hall. Let's say thank you all for participating. We actually have some time for Q&A, but I wanted to stop by asking you all, please come to the wrap up on Monday, April 22nd at 4:30 to 5:45. We have a lot of people live registered already. So if you're registered live and you would be okay watching it on Zoom at home, we would ask you to do that. But certainly if it's easier for hearing or mobility or whatever to come live, we definitely want you to be able to participate in the wrap-up town hall. By then I will have had a little space to digest all of this. The national reporters are actually going to be putting articles together. I actually had an earlier interview this week with CNBC, who said that this is such a heartwarming story that you all are pulling together, that they were going to be sending an NBC film crew live. So I actually talked to you all, some of you already, to see if they did decide to do that, if you'd be willing to talk to a reporter about what NFIM has meant to you personally and whatever perspective you want to give on the situation. So please register for that follow-up on April 22nd. I want to wrap it up before the Q&A to be clear on, at this point, April 12th, of what I'm thinking for this pivot to direct primary care. First of all, I'm convinced that direct primary care, based on everything I've studied, is a great way to take care of our patients in the way that I believe and many independent doctors believe can be increased patient access, decrease patient cost, increase practitioner wellness, and overall be able to practice great medicine for you all. So I'm planning on that pivot in January 1st of 2025. I will be opted out of all insurance relationships. Right now, we have 3,500 patients. We hope that you don't leave early. We're continuing all of our contracts until 12/31 of this year. So that's 9 months of lead time for you to look at your open enrollment of where you work, or look at the Medicare advisors that you work with, and figure out maybe October 15th when they open enroll that maybe there's a different Medicare plan that could actually cover your $1,200 investment in your primary care. I'm not an expert in that area. I've asked people who are expert to reach out to me so that I can involve them in town halls. I'm actually going to have another town hall monthly until we transition. So we'll be having town halls monthly. The next one again is a wrap up April 22nd, but I plan on monthly ones until December and maybe into January. So everything's the same. We have 3,500 patients. We're entering now a hybrid model where we've already enrolled 3 or 4 active DPC modeled patients who are outside of our insurance contracts or who are self-insured. They're already doing that. So we have this hybrid time until 12/31, and then we're looking for this model, but to be successful, we have to have 1,800 people enrolled by December. Now, we currently have 3,500 active patients. When we did our survey, and we're going to ask that you participate in the survey if you haven't already, 20% or 1 in 5 of you all said that you would enroll in direct primary care. And when I did the math, that's only 700 out of my 3,500 patients, which is why I made a decision, because prior to this, we've only allowed people who lived within 50 miles of Gainesville to join our practice. We have sent so many people away because Dawn and I are certified in functional medicine. There's a high demand. There's only 29 in the state of Florida that are IFMCP, functional medicine certified practitioners, of which 2 of the 29 are right here. So we've always had people asking to come from Miami, from Tampa. We've always said, no, you can't, because you're outside of a 50-mile radius. There's 2 reasons why I'm opening it up now to the entire state of Florida. One is, with this model, we have freedom to do telemedicine for our patients. So I thought that since we're licensed in Florida, that we would be able to take care of them. The only requirement is that they show up once live for their annual physical. And certainly if they have something acute that needs to be seen physically, that they have a good urgent care center or someplace where they can be seen wherever they live. The second reason is, when we did the survey, only 1 in 5 or 20% of you all said that you were willing to pivot with us. And again, that's only 700 patients, whereas for this model to be successful, to continue to serve you, I have to have 1,800 patients. So that's the thinking behind opening it up to the entire state of Florida. In addition, we're getting licensed in Georgia because we have a lot of South Georgians, Valdosta people, come to Gainesville. So once that happens, we're opening up our panel to Georgia. So there's a little bit of urgency on your end to tell us if you want to what's called pre-enroll. You're currently an NFIM patient. Let us know that you want to pre-enroll in January, and we'll get back with you as to how that's done. That said, because we're in such a tight cash flow issue, we have a tight cash flow issue right now. I actually, for the first time, I said it yesterday, and people showed up with checks this morning. Just this morning alone, people gave me checks for $6,000 to prepay for January 1st of 2025 to December 31st of 2025, because they know that we're in such a cash flow. We have a crunch right now. I'm working on the actual contract. Thank you all for coming. But yes, I am accepting those payments as well. And again, if you're youthful, if you're in the youth age under 30, it's $600 a year. If you're middle-aged like me, it's $900 a year. And if you're a senior, it's $1,200 a year. If you come and prepay for 2025, you're going to be enshrined in my lobby forever as NFIM, North Florida Integrative Medicine, Direct Primary Care, DPC pioneers, because you believed in the model, you believed in this model of healthcare, you believed in the model even before it materialized for you. And I'm so, so grateful, especially to the 20+ people who already signed up since yesterday to pre-enroll for next year, that you actually believe in this type of medicine where we put you at the center of the relation. So this email is very important. Everybody on the call, please memorize it if you can, because it comes directly to me. I'm seeing them all. NFIM DPC for direct primary care at gmail.com. NFIM DPC at gmail.com. There's a lot of emails on there. I'm trying to get through them all now. So, and I have a team at least responding. There's no autoresponder on this, but tell me if you're mad that, oh my gosh, why are you doing this? Or tell me, you know, I have some margin. I can go ahead and prepay for next year. I feel like George Bailey from It's a Wonderful Life, that you all are responding, and it's making me fight harder. 2 of my patients have offered $50,000 loans each. One was because her mom I took care of, and she died a couple of years ago, left her an inheritance, and she's willing to loan it to us to keep going. This is the survey. It's a simple survey. It'll take you 60 seconds on a scale of 1 to 5, with 5 being I'm for sure going to pivot with you, Dr. Akey, January 1st of 2025, or 1 being no way, no how, I'm leaving you, or whatever. And then in between, that we can answer some questions and come to town hall. Please don't panic and just leave. It broke my heart that 4 people got my invitation to town hall and decided they were just going to leave. A, I didn't get a chance to say goodbye, and B, I didn't get a chance to recommend where they can land softly and transfer the records. So we have a full 9 months to do this very strategically and very calmly. So I'm just asking you, please don't just leave. Okay, continue with us for your patient care. And like I said, I'm getting curated list of doctors who are still open to new primary care patients. So this is the survey. If you can't use a QR code for whatever reason, email in and we'll send you the survey again, but it's the same survey that we published on the Constant Contact. Thank you for joining us. We have Q&A now. Currently, the QA is being recorded, but I will stop if you raise your hand and don't want the QA to be recorded. I'm also happy to stop the recording, but I'll put you on later. So if you put in the chat that you have a question, but you'd prefer it not being recorded, that's fine. But please don't identify yourself either by name. Okay? So let's go ahead and open it up. Caitlin, come on up here. Yesterday, we made the mistake of not asking the question out loud. So there was a little confusion. So Caitlin's going to come up here. This is our 4th town hall. We're getting better and better, I think. So Caitlin, use your speaking voice nice and loud.
Hello, everyone. So the first question is, this new plan makes a lot of sense for those who are chronically ill, but for those who are healthy and see the doctor once or twice a year, that works out to $1,200 per visit. Why is this beneficial to the healthy patient?
Okay, so our practice is focused on wellness and accessibility. So you won't always be healthy, number one. And number two is we have special training in functional integrative medicine. When you come to the group medical visits, I do believe that you will find value in learning the state-of-the-art ways to be well, to reverse chronic disease, to keep your brain optimally well. That value in and of itself is $3,500. I do over 50 per year, of which it comes with your membership. So that's a high value. If you believe that your health care should be sick care, then what your statements absolutely may not be right for you. If you believe that you want to be on the cutting edge of optimal wellness, then you would find value in staying with us. In addition, finding value with staying with us so that we are there when you are sick, that you have a primary care home that knows you and actually cares about you. Second question. Okay. I'm sorry.
She has a question, so you can ask her to unmute.
Okay.
She's already.
You go ahead and do that on the computer.
Hello.
So, but don't use a name.
Yes.
Just go ahead and ask him.
So, somebody asked to unmute in the chat, so you can go ahead and unmute and ask your question.
Okay, that was me, Miss. Anyway, as a licensed insurance agent, there are a couple of things that my husband have been thinking about and trying to make the decision to continue on with you. And we would definitely like to do that. But for people who have HMO, they have to have a primary care doctor who is in network. So that's going to be a conflict there. We're going to have 2 primary care doctors in order for the insurance to honor prescriptions, lab tests, any test for any kind of imaging is going to have to come from the primary care doctor who is in network. So how is that going to work with you?
I have a couple. Thank you. Let me repeat the question as I understand it. The first thing is, I want to just say for the record that insurance does not equal healthcare. That the reason why we have a 9-month lead time is that you all have time to look at other options if you want to participate in our NFIM DPC model, including other options that you're currently in. The one that works extremely well with this model are high deductible plans, but also health share. For example, Samaritan Health Share works really well. And I can forward on the follow-up email a copy of an article that Dr. Chad Savage wrote on his personal journey through healthcare insurance and how he and his family landed at direct primary care with a Samaritan Health Share. So that's my point number one. My point number two is about your HMO question. To explain for everybody, HMOs are a network that's very restrictive with usually decreased premiums. So when you purchase a healthcare plan, you need to be aware whether or not you have, what kind of plan you have. You might actually be opting into an HMO plan. The other DPC doctors in the past have had to write recommendations to your HMO doctor. Whether or not they accept the recommendations, it's actually up to them because they are your HMO doctor. So I would do a bump. I do see that Ms. Gauthier, who's a Medicare advisor, is actually on the call. And just to be clear, I have no financial relationship with Ms. Gauthier. And if anybody on the call has an expertise in Medicare or any other type of insurance, please reach out to me at that, even at that email, because I would love you to be able to come at town halls and have these conversations. I cannot be responsible for what my 3,500 patients choose in terms of their healthcare insurance. So that's why I've asked people who know much more than I do. The other thing, the third part, and then I'll be quiet. Dr. Lee Gross, who was the first DPC doctor in Florida from 2008, who's still active in helping me to navigate all this. He was very active in lobbying in Florida to make sure that this is not considered an insurance. It's a relationship of a relationship between a doctor and a patient. It's not considered. DPC is not an insurance. It's outside the insurance model.
Okay, I have another question. I mean, if my husband, who you know his issues, needed to see a specialist, you know, that would be, I'm fortunate in that my plan is an HMO POS, so I don't need a referral to see anybody. But for people who have Medicare, you can't go sign up for a fee for service or anything like that because the laws are restrictive and it has to be in your area, offered in your area, and in this area it is not. So for people who are 65 or older, disabled, and collecting Social Security disability, that would be a difficult thing. Now they do have PPOs that you can sign up for with Medicare, and you know that is an option for us, but I just want to see how is it going to work if we need to go see a specialist, because my husband has had to see certain specialists that are very important for him.
I want to bump that. Ms. Gauthier, are you on? She's a Medicare advisor.
Hi,
Are you-
Dr. Akey. Yes, I am on. Thank you so much. If I may answer that question, I really hear the concern in this lady's voice. I'm sorry, ma'am, I didn't see who you were. Basically, just short answer. I know Dr. Akey is short on time. Short answer is I would strongly recommend you sit down with either myself or another licensed insurance agent. We are required actually to have about 65 to 85 hours of continuing educational credits just to speak about Medicare. So
Well, I'm a
some of the things
licensed
you
agent
mentioned
myself.
were not great. Well, some of the things you mentioned, I would say are not completely accurate. While there are some restrictions on Medicare Advantage, there are also a lot of things that aren't as restrictive that would fit Dr. Akey's model. However, with Medicare being so standardized, but yet individualized for each individual person's situation, I would recommend sitting down with somebody who sits down, who does Medicare, understands the IRMA rules, the Secure Act, and how government legislation really impacts your healthcare as it is. Because there is a one size fits all. I can't make a general statement and say a PPO is the way to go or an HMO is the way to go. There are many things that we can do to fit this model if that's what you like to have your healthcare served at, but also that will fit your lifestyle. So that was a long answer to say that you should sit down with a licensed professional.
And thank you, Rachel. Like I said, I've given us 9 months of lead time to sort this out. The enrollment for Medicare is not even until October. So please do not panic, everybody. We are here serving you as we always have until December 31st. And I will do my
Yeah,
very
they're
best.
just
to
not,
give,
they're not
people who
answering
are
me.
much smarter than I
Yeah,
am
I
on this
am a license.
as a resource. And that's another question. Okay.
The next question we have is, how can you target all 3,500 of your current patients if your model is based on 1,800 patients? How will we determine which patients are accepted into your practice? Is 1,800 a hard cap?
I don't know if y'all know this, but I have a passion for primary care and a passion for teaching young doctors and would-be doctors. I have tried for 2 decades to hire an MD or a DO. I was successful about 10 years ago for her only to quit because she couldn't do the insurance model. She's now a stay-at-home mom. I have reached out contracts with doctors trying really hard for 2 decades. I can't get anyone to want to do primary care, and it's not unusual. because most of the doctors are encumbered by $200,000 to $300,000 in debt, and everyone knows primary care makes the least and has the highest overhead with the highest headaches. So this model, everybody, will help me recruit high quality individuals. In addition, I'm planning on making this a National Health Service Corps forgiveness site so that we can forgive loans. So however, it's high on the priority list to forgive loans of the doctors that come back to serve our community. And that's a National Health Service Corps is basically, if you serve a population with wide SES, you can actually get that title. And that way, when you come back, when the doctor comes to join us, like I say, you have $300,000 in debt, you stay with me and every year the government will forgive you $20,000 a year. So that's very attractive. But more importantly, this model offers why they did family medicine or internal medicine primary care in the first place, so that we would have time to take care of you as an individual and not be burdened with the tremendous amount of pre-authorizations and paperwork and everything else that keep us here late every night. So is that a hard cap? No, I pray every day. Now I'm up to praying 2 hours a day. Honestly, whatever God tells me, I'll do. And I think that for our current team, 1,800 is what it is, but I have job offers out to that doctor who said she wouldn't join me unless I became direct primary care. I said, hey, I'm pivoting in January. Can you reconsider? And if she could, I'm done in 5 years, everybody. So I think I've said that before. She would be an excellent replacement for me as medical director and owner of this practice. And like I said, she wouldn't even consider joining me in the insurance model. She wanted direct primary care, but that's not why I'm doing this pivot. I actually told her, join me, you pivot when you have the practice. That's 5 years from now. She's like, nope, I'm not doing it. So I have a feeling I'm going to be able to attract really a passionate, heartfelt people who care about medicine to this model.
Okay, the next question is, can you speak more about the fee-for-service visits? As a relatively healthy person who normally only needs 1 to 3 visits per year and still needs to cover the cost of healthcare for the rest of my family, then $900 is out of reach. I'm also not close enough to regularly attend the group visits and get that additional benefit. Will the fee-for-service visits work for the typical annual exam?
So let's just roll this back and say, just to be clear, the group medical visits, because part of this DPC model, I'm out of insurance and government contracts. You're signing a release that said that you're opting out of HIPAA, that I can actually FaceTime you like we used to FaceTime you during COVID. That's the reason why it's all restrictive. The other thing is, once they called the pandemic over, everybody but Medicare says, oh, you have to show up in the office again, face to face, to go over your cholesterol labs. We're done with that. If it's a lab review, we're going to call you, we're going to whatever modality to get a hold of you. But the actual question is about, so just to be clear, you don't have to show up live to attend the group medical visits. You could come in on Zoom, your phone, or however you want to come in. It's part of your membership. So as for why I decided it's 2 fee-for-service visits is because I want to take care of your friends and family. Realize if you come in fee-for-service, you're not part of our DPC family. If you get sick, we are not obligated to take care of you because we're not your primary care home. If you're part of our membership, if you're part of our family, we're going to take care of you regardless of. The other thing is, if you're in Hawaii on vacation, guess what? We're outside of the rules of insurance. We can FaceTime you and take care of you, whereas we couldn't in the past. In fact, I told you guys, Medicare, I can't take care of you if you're outside of Florida on telemedicine. Sure, they lobbied and now we could do Medicare on telemedicine because they extended it, but you don't even know if that's going to be taken away in December. You have to re-lobby for that for the seniors. But as it is right now, we can't telemedicine you if you go to visit your grandchildren in New Jersey and get sick. It would be a call to us and say, sorry, Miss Patient, we can't take care of you on telemedicine because you're in New Jersey. You'll have to go to urgent care. Okay. Whereas with this model, we're not restricted. We'll take care of you. I mean, hopefully you don't call us from Italy when we're half asleep in the middle of the night. Okay. So, but anyway, those restrictions are gone. So as to your question, is there an annual wellness visit? That's not the model we're shooting for. The fee for service is 2 visits per calendar year, and they're primarily for your family. If you come in for those, your fee for service and you're not enrolled in our direct primary care electronic health record. It's a whole different system.
All right, the next question is, I was wondering with the Medicare insurance, when tests are ordered, will those fees increase since you are with direct primary care?
So the question is about Medicare and ordering tests. So I've had a PCOS number, which identifies me as a Medicare provider now for decades. So that said, just because I'm opting out of Medicare doesn't mean I can't order your MRIs, your referral to other physicians, your labs, et cetera. If you did not sign up for a restrictive type of Advantage HMO plan, so you're going to have to work with your Medicare advisors such as Ms. Gauthier, or whoever you have. Like I said, I'm not endorsing anyone in particular. So please, if you have expertise in this area or you have friends or family that do, let me talk to them because I'm going to have monthly town halls until we pivot in December and probably a couple months after to make sure there's a smooth landing. So under standard red, white, and blue Medicare, I can refer to other consultants like I have, manage your home healthcare, et cetera. So none of that's changed. In addition, I intend on continuing my chronic care management program, even without Medicare reimbursement for that, because that's a high quality, good thing for my patients.
Those are all the questions for now.
Okay, that's all of the questions. You all have been, any questions in the live crew over here? All right, so thank you all for coming. I really appreciate your interaction with us. Please take a picture of this email if you can't remember, nfimdpc@gmail.com. It's been a huge privilege to spend my entire professional career caring for you all for a quarter century in my hometown of Gainesville, Florida. I don't know what tomorrow will bring. I do know that I'm warmed, my heart is warmed by the amount of dedication that you have to each other, to our healthcare professionals, and to this practice in navigating your healthcare needs. At this point in April, this is the best option forward that I can come up with. I hope you all agree. I do want continued conversation and not a monologue here. So please plan on coming on April 22nd. It's a Monday at 4:30 to 5:45. Like I said, there's like 100 people already signed up and we're full live. So if you've signed up live and you can potentially come on Zoom, that would be really good. Otherwise, please continue the conversation. This email, nfimdpc@gmail.com. I'm watching that one directly. I'm just overwhelmed if I don't respond right away. But realize I watch that very, very closely, and stay tuned to national coverage. So like I said, I did an interview with CNBC on Monday, and I did a interview with Bloomberg today. So the press has gotten a hold of this. They love the story that small hometown doctor caring for her own patients for a quarter century did well. We did well through COVID, right? We did well through COVID, and now this Change cyber attack. United Health Group, 100% responsible for this, has not fronted us money to get us out of this. They have plenty of opportunity, 12 opportunities to help me. I've tried to get a hold of them. They haven't really responded. Now I'm pivoting to a model that in the end, I actually think will offer even better primary care for our population. So thank you so much for attending. And, I'm very humbled by this. This whole situation has been very humbling for me as a human being that actually cares. And you all rowing so hard with our team, Dawn, Joey, Shauna, and our 15 employees, interns, and everybody who's going to be a doctor in the future. Thank you, by the way, to Caitlin, Alex, and Sarah, and Joey for being here from our team, and Dawn remotely. Ms. Gauthier, Rachel Gauthier, thank you. I have her cards if you're interested in picking up her cards and having a conversation with her or any other expert. Talk to someone else besides me. I can't be responsible for what kind of Medicare line you end up picking in January, but I can be responsible if you decide to stay with us for offering the best primary care that I know how to deliver with our team. So for now, be safe, be well, and God bless you all. Thank you so much. Thank you all for coming.